Her mentor is Dr. Jeffrey Lake. The title of her presentation today is Ostracized, the Effects of Obstetric Fistulas in the Developing World Childbirth. So let's welcome Emily, give her a warm greeting, and so get started.
All right, well, thank you for coming this afternoon. Like she said, I'm going to be talking on obstetric fistulas. And at face value, indeed this is a biological issue and an injury. But as we progress through the talk, I just want to bring your attention to some of the aspects and consequences that might not be obvious at first, and they deal with much more than biology and will indeed draw from all 5 of our ribbons today. And our focus group for this study was the women of sub-Saharan Africa and Asia. And obstetric fistulas develop from obstructed labor, so this is where we will start. Obstructed labor can occur because of malpresentation of the fetus, which is anything but the head of the fetus presenting through the birth canal first. So say an arm or a leg, the baby will then be stuck in the birth canal. Cephalopelvic disproportion, this is when the fetus is too large to fit through the mother's pelvis. Or abnormal contractions, whether they are too weak, too short, or uncoordinated, this can also cause an obstructed labor. When an obstructed labor occurs in an industrialized country, a woman would go in for a C-section and that pressure and that danger would be removed. However, for the women that I'm focusing on, they might not have that option for one reason or another. A normal labor is 10 to 12 hours, and anything beyond that is considered a prolonged obstructed labor. And some of the outcomes are listed here. It's estimated that 600,000 to 1 million women die each year from childbirth causes. Now, for every woman that is killed or dies because of a childbirth cause, 20 to 40 more are injured, and this is maternal morbidity. And obstetric fistula is one of those morbidities. And it's estimated that 1 to 2 million women worldwide are currently suffering with this injury. And it's divided into 2 classifications, a rectovaginal fistula or a vesicovaginal fistula. The last outcome is fetal mortality. In the labors of which the women developed a fistula, 90% of them also had a stillbirth. Labor will not stop until the fetus is born. And so what happens is the child will die of asphyxiation or sepsis, and the woman will stay in labor. Sometimes we're reported up to 10 days until the fetus is decomposed enough and is able to pass through the woman's pelvis. So here we have the classifications. The rectovaginal fistula, here we see the fetus's head is pinching the soft tissues of the mother's rectum between its head and her spine. And then in the vesicovaginal fistula, which is more common, which is why it started, the soft tissues of the bladder are pinched between the fetus and its pubic bone, or the mother's pubic bone. What happens is labor continues and the pressure increases, and that cuts off the blood supply to that soft tissue. The tissue becomes necrotic, so it dies, and then it sloughs away, and it leaves this hole, which is the fistula. It's the abnormal passage between the bladder or the rectum and the mother's vagina. And the result of this is that the woman becomes incontinent. She can no longer control the flow of urine or feces. So why does this happen? Here I have a list of some of the contributing factors, and I would just like to highlight a few of them. And I want to define what rural means for these women. To give you an idea, 75% of Ethiopia's population lives an average of a 2.5 days walk from an all-season road. So rural isn't an hour out of town. Rural means a very long way from emergency care. Malnourishment plays a huge role in the cephalopelvic disproportion and the abnormal contractions. As the mother grows, obviously if she's malnourished, she's not able to grow fully herself, and the pelvis is too small for the fetus to fit through. Likewise, if she becomes pregnant while she herself is still growing, there becomes a battle between the fetus and the mother for those scarce nutrients. gravida, this means that it was the woman's first pregnancy. 50% of the women who developed the fistulas, this was their first pregnancy. And she's likely now without a child because it was a 90% chance that she had a stillbirth. We saw an increase if the woman had 4 or more births again. So the desire for large families can also increase the prevalence of fistula. So what does a typical patient look like? And this is from a study of 899 Nigerian fistula patients. And the averages here are bolded. The average woman was 4'11", so very short. She was thin at an average of 96 pounds. And she was young. When she came for treatment, the average age was 27 years. And this doesn't mean that she got the fistula when she was 27 years old. This is when she came for treatment. As you can see below, 41.5% of women sought treatment 1 to 4 years after they developed this fistula. On average, they reached menarche, or their first menstrual cycle, at 14.5 years, were married at 15.5 years. So these are really young girls, and we can see how the malnutrition or how they might not be big enough to give birth, and that's why it's such a big problem. In addition, when they showed up for treatment, 50% were abandoned by their husbands, whether that was formally through a divorce or just separated. So what does the life of a fistula look like? Obviously, they're going to have incontinence of urine or stool. As you can see in the photo, if they stay in one spot too long, they'll leave a puddle below them, and it's very obvious. They're surrounded by an unmistakable odor, and they're an offense to those around them. Additionally, so these women have gone through a very traumatic labor, as I said before, sometimes up to 10 days. They're exhausted and they're injured, and they have multiple injuries that they're prone to. They can have foot drop, which is a neurological disorder where it's either permanent or it can be temporary, but they can't move very well. They're prone to infection, kidney disorders, and ulcers. And on average, these women can't move about 30 days after this birth, so they're literally lying on the floor for 30 days until they can move and seek help if nobody else helps them. Now, these are just the biological factors. Additionally, they experience shame and isolation. Put yourself in the shoes of these women for just a moment. They don't understand why they've gotten this injury. They're led to believe that maybe it's a venereal disease or a punishment from God, a sign of infidelity. They don't understand and they feel shame, and their worth is based upon the ability of having a child, and now they don't have a child. Having a child seems very far out of the picture for the condition that they're in, and that shame can drive them into isolation. And so this is where they are ostracized. Their family pushes them out. These conditions can lead women to take their own life, or if they are still connected with their family, there are reports of honor killings where the family will try to protect the name of their family. But treatment is hopeful for these women. Some are healed with just a catheter, but many need a surgical operation. There's the Martius graft, which is the most common, in which they take a fibrofatty tissue from the woman's labia and use it in the surgery to patch the hole. Another is the Gracilis graft, and they use the muscle from the woman's inner thigh, as you can see here, to patch more severe cases. And then the most severe have the option of a ureter diversion, in which the ureters are connected to the colon. So how do these women fare the treatment? Well, they do really, really well, as we can see from these two studies. On the first try, 88% of the fistulas were closed. Around 6% were failed, although this doesn't mean that the fistula will never heal. Sometimes it does take 2 to 3 surgeries to successfully close the fistula. 6% did have stress incontinence, and this is a sign that the actual mechanism for continence was probably disturbed during the fistula, and she might not be able to have continence. So if the stress incontinence is if she sneezes or coughs, she might she might still have a little bit of leakage. And then in this next study, on the first try, 95% of the fistulas were closed, and of that 95%, 93 were continent. So again, we see some of the stress incontinence. And this study reported a mortality rate. And it's actually very surprising and a testament to the treatment that these women get that the mortality rate isn't higher. They come in such a grave physical condition that to only have 7 out of almost 1,700 patients die, it's a really good testament to the care that they get. Pitfalls of these treatment. So it's difficult to obtain informed consent, and I'll get into that in just a moment. Post-operative care is a challenge. If you remember just what rural area means, these are the roads that they have to travel those 2.5 days on, or even more. It's a very hard journey. So they can't be going back and forth for their post-operative care. It's difficult to give holistic treatment. So again, I mentioned that this was a biological injury, but they also have economic consequences, they have psychological consequences, social consequences, and all of those issues need to be dealt with. And there are also delays in their seeking care. The delays are divided into 3 categories. The first being the delay in deciding to seek care. So these women's reproductive capacities are often under control of another man, so say their husband, their father, their brother, and they'll have to ask permission to go and get this treatment. Some think that it will heal on its own, or if they have been abandoned by their husband, they may have no source of income to fund their trip and stay and care at a hospital. There's a delay in arriving at a suitable obstetric care facility. So there's no emergency services. If they want to make a trip to an obstetric care facility, they have to walk themselves, or they could be carried on a homemade stretcher from people in their community. There's also a delay in receiving appropriate care at that facility. As I mentioned before, these women have an odor. People won't understand unless they understand the injury. And because they're an offense, sometimes they won't even be able to receive care at those just general hospitals. They need a specific obstetric care facility. Some of the pitfalls of treatment is informed consent again. So put yourself again in this woman's shoes. You have a document before you that's very detailed. You're likely illiterate, you're not able to read it, and you're relying on a surgeon and a translator to help you understand this document, and you've likely never encountered what informed consent actually means to give. And this was from a case study of a woman facing urinary diversion, and it just shows some of the barriers that these women face. It says, not only are the surgeon and patients usually separated by culture, skin color, and language, but their general worldviews, life expectations, and basic understanding of what the human body is and how it works may be almost incomprehensible to one another. So the informed consent is not a permission slip. It's helping her to understand that she has the right to choose her care based on her values and her wishes, which is a very foreign concept to these women. So that just shows that these women are part of a vulnerable patient group. And here are just 3 examples of why they're also in other vulnerabilities. One being cognitive vulnerability. And the question to ask for this is, does the patient have the ability to deliberate or decide whether to receive the care or not? Again, they're illiterate. Special precautions need to be taken to help ensure that informed consent is truly informed consent. They don't understand the cause of their injury, and likewise, they might not understand the requirements that surgery will impose upon them. Allocational vulnerability. Is the patient seriously lacking in social goods that may be provided as a result of their participation? And this is things like clothing, food, and other provisions. Now, it's not a bad thing to give these women those things, like they need it. But the facilities need to understand that when they're offering these goods, it's an incentive to an impoverished woman. She needs these things. And so they need to hold up their end of the deal, the medical end of the deal, when they offer those goods as well. And then medical vulnerability. Is the patient selected because she has a serious condition of which there's no satisfactory remedy? She has nowhere else to turn. She has been turned from her family and her community. So if you as a surgeon come to her and say that you have a solution, you will have her trust whether you deserve it or not. one of the concepts that many of the papers that I read emphasized was that fistula tourism and surgical crusades are not the answer. Many surgeons that come to help these women, of course, many are propelled by a good heart and good causes, and even they can still do harm. But there are other surgeons who will come to this area who are just looking for good stories, looking for experience, and looking for a chance to try out methods. And these women deserve more than that. We need to protect them from that harm. They need long-term solutions and support. This is where the fistula hospitals come in. This is a photo of women performing a song called Fistiari Dandinia, which is translated to urine oppressor of the world. Now, when we hear that translation, we think, well, this must be a very mournful, a very sad song from what all these women have been through. But it's actually a praise song. These women have found community acceptance, and they can celebrate that at this fistula hospital. They thought they were alone for the rest of their lives, just surrounded by this odor and in poverty. But at this place, they have found other women who are going through the same thing, and they have found hope through the treatment that they're given, very successful treatments. They have more time to heal and stick around the hospital until they can get back on their feet. And these special fistula hospitals will also provide provisions. Moving forward, what do we need now? Many of the articles emphasize fistula champions, and these are people who are already in the community who will help these women to understand that they do have hope, there are resources available for them, and that they can go to get treatment. Trained midwives are also very important because one of the key components of eliminating this injury is that they need to seek emergency care when a labor becomes obstructed. And a midwife can help with that. We need to have people dedicated to the cause. We can't have people going for it just 2 weeks or a couple months to go do surgeries and leave. They need long-term support. There are already resources available to them. There are many fistula hospitals that have amazing services that need to be expanded, and we need to provide support to those that are already involved. And lastly, we need to educate them. Again, it's great to do the surgeries and to help these injured women, but it would be even better if they'd never had to experience it in the first place, and if they understood how the injury occurs and what they can do to prevent it. Here are my references, and are there any questions? Yes, ma'am.
How did you get interested in this topic?
It was actually brought to my attention by my mom. She's a physical therapist, and she's very involved in women's health. So she mentioned it, and I thought it was very interesting. Yeah. Others, yes.
Yeah, so this was really good and really interesting. And you sort of got to this at the end of your presentation, and I was wondering whether perhaps you could say a little bit more about it, this sort of issue of cultural differences, like different worldviews, expectations, and this phenomena of fistula tourism and things like that, right? And you present this list of solutions.
Yes.
Right?
Oh, sorry, go ahead.
Yeah, so I mean, I think the question I have is, how do we, it seems like you're talking about a very fine line that we have to tread between impose sort of a cultural oppression, right? Coming in saying, this is what you're doing wrong, we're going to do all this, and we're going to fix you, and then we're going to get out, right? And actually working within cultures for long-term solutions, right? And so I was wondering if you had thought a little bit about how do we do that? How do we continue to support these efforts without engaging in sort of cultural oppression and saying, no, it's your culture that's bad, right?
Mm-hmm.
We're going to make it.
Yeah, absolutely. I think part of that would just be coming in with open ears. The quote that I actually read from the informed consent, the woman chose not to go through with the surgery because she would rather having that incontinence rather than all of the other complications that could have arisen from her surgery. And so it's listening to the patient, what they want, because for me, I would say that would be devastating to be constantly incontinent, but we have to realize that what we feel is devastating is not devastating, or it may not be devastating to someone else. And so there is a very fine line, and I think that we just need to come in with open ears and listen to what they're looking for in their treatment, and if that is what we can provide, then we'll provide it. And if not, then we need to be big enough to say that we won't force this treatment on you, and we'll try to help you with what you're looking for.
Our time is concluded. Can you make it very quick?
I get the
All right. I apologize. We need to keep a tight time frame today. Let's thank Emily for her presentation.